Orofacial pain part 3. Neuropathic pain, facial, post-herpetic neuropathy, facial pain associated with herpes zoster. Acute herpes zoster. Acute herpes zoster or shingles is a reactivation of latent varicella zoster virus infection that may occur decades after the primary infection. Herpes zoster is a disease of the dorsal root ganglion and therefore induces a dermatomal vesicular eruption. Trigeminal and cervical nerves are involved in up to a quarter of cases. The ophthalmic branch is affected in more than 80% of the trigeminal cases, particularly in elderly males. The vesicles and pain are dermatomal and unilateral, which is a very important feature, and may appear intraorally when the maxillary or the mandibular branches of the trigeminal nerve are affected. Clinical features usually begins with a prodrome of regional pain, itching, and malaise. Pain precedes typical vesicular eruption by less than 7 days, usually 2 to 3 days. The dermatomal vesicular or herpetic eruption will rupture and dry out over 7 to 10 days, but complete healing may last up to 1 month. The pain is moderate to severe, with a visual analog scale of 6, and may persist for 3 to 6 months. Treatment. Therapy is directed at controlling pain, accelerating healing, and reducing the risk of complications such as meningitis, post-herpetic trigeminal neuropathy, and local secondary infections. Antivirals should be initiated within 72 hours from the onset of rash and will significantly decrease rash duration, pain severity, and the incidence of post-herpetic neuralgia. This is particularly effective in patients above 50 years old. Fever and pain should be controlled initially by mild analgesics. Use of glucocorticoids is controversial, but may help reduce acute pain. They should always be used together with antivirals. Post-herpetic neuralgia. Up to 1/5 of acute herpes zoster patients will suffer persistent pain 3 to 6 months after acute herpes zoster infection. By 1 year, however, only 5 to 10% will suffer pain. In advanced age, above 50 years old, severe prodromal pain of visual analog scale more than 5, severe acute pain, and severe rash are risk factors for persistent pain. In patients older than 60 years old, 50% or more will continue to suffer pain for more than 1 year. Features of post-herpetic neuralgia. Post-herpetic neuralgia is a dermatomal disease persisting or recurring of more than 3 months after the acute herpes zoster stage. Post-herpetic neuralgia rarely affects the trigeminal nerve, and when it does, it is mostly in the ophthalmic branch, which accounts for 22% of post-herpetic neuralgia patients. Patients relate a previous herpetic dermatomal eruption that was preceded by pain, usually 2 to 3 days, but up to 6 days prior. Post-herpetic neuralgia pain quality is burning, roping, stabbing, shooting, or sharp. Burning pain is significantly higher in patients not treated with antivirals for acute herpes zoster. Itching is very common and prominent in trigeminal dermatomes, and may be subjectively graded as worse than pain. Pale, sometimes red, purple scars that are usually hypoaesthetic or anesthetic, but with aldynia and hyperalgesia may remain in the affected area. Treatment. Early treatment of established post-herpetic neuralgia improves prognosis. Ophthalmic post-herpetic neuralgia seems to have the worst prognosis. Evidence-based treatment options of post-herpetic neuralgia include tricyclic antidepressants, drugs like gabapentin, also topical lidocaine patches can be used. Burning mouth syndrome is a poorly understood pain condition that is most probably neuropathic. The condition is also known as stomatodynia and is characterized by a burning mucosal pain with no significant physical signs, and is common in postmenopausal women. Burning mouth syndrome may be subclassified into number 1, primary or idiopathic burning mouth syndrome, for which a neuropathological cause is likely and cannot be attributed to any systemic or local cause. Number 2, secondary burning mouth syndrome, resulting from local or systemic pathological condition, and it is characterized by resistance to a wide range of treatment and is one of the most challenging management problems in the field of orofacial pain. Clinical feature of burning mouth syndrome. The primary location of burning complaint is the tongue, usually in the anterior two-thirds of the tongue. However, usually more than one site is involved, and in addition to the tongue, hard palate, lips, and gingiva are frequently involved. Pain is most commonly described as burning or hot, and intensity varies from mild to severe. Burning mouth syndrome is typically of spontaneous onset and lasts from months to several years. Although a chronic unremitting pattern is usual, partial remission has been reported in about one-half to two-thirds of patients, 6 to 7 years after onset. Spontaneous remission is very rare. Common aggravating factors include personal stressors, fatigue, and specific foods like acidic, hot, or spicy. More than two-thirds of patients complain of altered taste sensation, dysgeusia, accompanied with burning sensation. In many cases, described as a spontaneous metallic taste. Abnormal sensations, such as feeling of a dry mouth, are common, but true hyposalivation is less common and should be considered under secondary or symptomatic burning mouth syndrome. Oral and perioral burning sensation as a result of local or systemic factors or diseases is classified as secondary burning mouth syndrome. We have either local factors and diseases like oral candidiasis, lichen planus, and allergies, while systemic disorders like hormonal changes, deficiencies of vitamin B12, folic acid or iron, diabetes mellitus, side effects of medications, and autoimmune disease. Successful treatment of the primary disease will usually alleviate the burning sensation in secondary burning mouth syndrome patients. Treatment of burning mouth syndrome. Topical therapies may be effective and are useful in elderly medically compromised patients. The most established is clonazepam tranquilizer of 1 mg and should be sucked 3 times daily. Also, topical anesthetics may decrease or increase the pain. Systemic therapies include paroxetine, which is antidepressant, 20 mg per day, and sertraline, 50 mg per day. These may reduce pain and improve anxiety and depression. A 2-month course of 600 mg daily of alpha-lipoic acid may be beneficial. A combination of alpha-lipoic acid and gabapentin results in a greater improvement of the burning mouth syndrome compared to these medications if are taken alone. Pharmacotherapy resistance burning mouth syndrome has been associated with underlying psychological distress, and these patients may particularly benefit from cognitive behavioral therapy. Painful post-traumatic trigeminal neuropathy. Some patients develop chronic pain following negligible nerve trauma, such as root canal therapy, or following considerable injury to nerve bundles, such as in fractures of the facial skeleton, following dental implant surgery, following orthodontic jaw surgery, and this may remain with permanent sensory dysfunction, but the incidence of chronic pain is unclear. Features. Chronic pain issues are possible risk factors for the features following identical injuries. Onset of neuropathic pain and its characteristics varies from patient to patient. Such variability is probably due to a combination of environmental, psychological, and genetic factors. The presence and duration of pain in the tooth, tenderness to percussion, female, gender, previous painful treatment in the orofacial region, and concomitant chronic pain issues are possible risk factors for the condition. Pain is unilateral and occurs in the area of injury or at the distal dermatome of an injured nerve. Initially, pain may be precisely located to the dermatome of the affected nerve, but it may become diffuse and spread across dermatomes. Pain is of moderate to severe intensity of visual analog scale 5 to 9, usually burning inequality, but also stabbing during exacerbations. Positive or negative local neurological signs include clinical, demonstrable sensory dysfunction, usually allodynia, hyperalgesia, or paresthesia. Most cases are continuous, but some report superimposed paroxysmal pain attacks. Less frequently, there may be short-lasting pain with associated mechanical trigger areas, mimicking trigeminal neuralgia. Rarely, a subjective feeling of swelling, foreign body, hot or cold, local redness, or flushing may be reported, but these may not always be clinically verifiable. Topical anesthetic may be successfully employed in the management of painful neuropathies. Also, topical medications are used, maybe a single treatment, or in combination with systemic medications, can reduce the severity of orofacial neuropathic pain. Systemic pharmacotherapy, therapy of neuropathic pain with any of the established drug groups, antidepressants, anticonvulsants, and opioids, leads to improved the quality of life, sleep, and mood. However, pain intensity is reduced by 20 to 40% in only a subset of responders, and is usually accompanied by significant side effects, particularly at the higher doses often required in neuropathic pain. The last treatment of painful post-traumatic trigeminal neuropathy is surgery.